So thanks everyone for joining us for the No Neuropsychology Didactic series. My name is Josh Fox-Fuller, and we're pleased that you can join us today for this volume 6 lecture that brings you experts from the field covering different topics in neuropsychology each week. So just a few housekeeping items before we get started with today's talk. So importantly, this series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. And we would like to thank our continued financial support from our individuals, organizations that support neuropsychology. Importantly, we're so pleased that you could be here for the live webinar with Dr. McLaughlin today, but all of our recordings from the past lectures and our neuroanatomy series are available on our website and on YouTube. So be sure to follow us and subscribe to make sure you stay up to date with all the great educational material we are creating. Some of the interesting things that we do too on the No Neuropsychology website is we have created some, through a partnership with Apps, we've created some quiz materials on some of our talks. So be sure to check that out as well. So a few disclaimers for this series. The lectures that we do are not intended to replace formal training in neuropsychology, and the views of the speakers are entirely their own. So today we'll have an opportunity at the end of the talk for a moderated question and answer period. So please submit any questions you have at any point during the talk to the Q&A box at the bottom of your screen. And I will do the moderated Q&A with Dr. McLaughlin at the end of the talk. And the recording will be posted later this week on our YouTube page. So with that, I'm going to go ahead and turn it over to Dr. Nicole McLaughlin for her talk today entitled Neurocircuitry-Based Interventions for OCD. So Dr. McLaughlin has a PhD from Suffolk University and completed internship and postdoctoral fellowship through the Brown Clinical Psychology Training Consortium. She's a neuropsychologist and a director of the psychiatric neurosurgery at Butler Hospital. And she is an associate professor on the research scholar track through the Alpert Medical School of Brown University. Dr. McLaughlin has extensive expertise in the examination of frontal subcortical functioning in neuropsychiatric populations through the use of cognitive tests and neuroimaging. Her background includes expertise in deep brain stimulation, ablative procedures, and non-invasive brain stimulation for OCD and other neuropsychiatric disorders. And over the past several years, her research has been has focused on measurement of change after these types of interventions. Dr. McLaughlin has been continuously funded through the National Institutes of Health since 2008, and she has published over 50 journal articles relating to OCD and other topics of disorders. So with that, I'm going to stop sharing my screen and turn it over to Dr. McLaughlin for your talk. Thank you for joining us today.
Thanks for that introduction, and thank you for inviting me. Especially thanks Sarah, who's my resident right now, who invited me here to talk. So I appreciate it. So let me just share my screen as well here. Let's see. Give me one sec. All right. Okay.
That looks good. Thank you.
Okay,
yep.
Fantastic. All right. So as Josh mentioned, I am the director of psychiatric neurosurgery at Butler Hospital and the lead of our neuropsychology program there, and an associate professor at the Alpert Medical School on the research scholar track. But I do a lot of clinical work as well, obviously neuropsych assessments, both inpatient and outpatient, and do all of our pre and post surgical assessments for our OCD patients who are undergoing DBS or ablative surgery. So I look at things from the clinical side as well as the research-based side. So let's see here. So here's just a quick overview of what neurocircuitry-based interventions are, because that's kind of a vague term, and that could mean lots of different things. I've also used the term neurotherapeutics, and essentially these are really just interventions that directly impact the brain. So what I'm going to talk about today are some invasive and non-invasive neurocircuitry-based interventions. So invasive being deep brain stimulation, as well as lesion or ablative surgeries, and also non-invasive techniques like transcranial magnetic stimulation, transcranial direct current stimulation, and a little bit about low intensity focused ultrasound or LIFU. And I am going to focus on OCD, though certainly these interventions are used in other disorders as well. So I'm just going to give a brief overview about OCD and talk a little bit about the population that I most often work with these interventions. So a lot of you probably know this, 1 to 3% of the population have OCD. OCD is the anxiety disorder with the highest percentage of serious cases. And so we have obsessions, which are the intrusive thoughts that cause distress or discomfort, and then compulsions, which are the behaviors that are carried out to reduce that distress, at least temporarily reduce that distress. And so we see patients with all different types of OCD. So we see patients with contamination. We see patients who, most of them have doubt. So this what if concern about what if this could happen, and checking behaviors, as well as incompleteness or feeling like something has to be just right. Thoughts of symmetry, things have to be arranged in a certain way, taboo thoughts. So intrusive sexual thoughts or aggressive thoughts. And these are certainly not mutually exclusive. A lot of our patients have a lot of our surgery patients who are extremely severe. So they are in the severe to extreme range on the Y box, which is what we use as a gold standard measurement of their OCD severity. And they are extremely impaired by OCD. And so that can mean that some of them are working, some of them are able to hold down jobs, but maybe not as effectively as they might otherwise if they didn't have this severe illness. Or if they are engaged in work, they're constantly distracted by these thoughts, or they're late to work and maybe have struggled finding a job where they can actually stay because of these things getting in the way so much. Or certainly some of them are not working or on disability, and some of them are even homebound and really just unable to leave the house because of the severity of their illness. So OCD, this is a really simplistic diagram, especially speaking to neuropsychologists. But OCD generally affects the fronto-striato-thalamo-frontal circuit. So we see that at least in what we probably consider harm-avoidant OCD, the limbic circuit is probably quite involved, and we see that in imaging scans. And so what we're seeing is hyperconnectivity between some of the deep subcortical areas of the brain as well as the frontal systems. What we're starting to realize, so I mentioned those symptom subtypes a minute ago, and kind of how we've characterized them traditionally is looking at kind of 4 or 5 symptoms. So something like contamination, these religious ideas, and that's how our OCD checklist is actually broken out when we're doing it with the patient. However, those symptoms don't seem to map very well onto neurocircuitry. What we're starting to learn, and we still have a long way to go in kind of characterizing this, is that there might be actually a differentiation between the harm avoidance subtype of OCD. So those patients who are doing something because they're worried about something bad happening. Like, I'm going to wash my hands because if I don't wash my hands, I'm going to get sick, or something bad's going to happen to someone I love, which seems more kind of fear-based, versus a patient who might have more incompleteness symptoms. So they're doing something until they get this signal in their brain that says, okay, this is done, this is complete, this is just right, I finally finished it. And something kind of clicks in their brain. And that seems to be more of an error monitoring signal versus a fear signal. And so this diagram here probably characterizes pretty well that harm avoidance subtype, but that incompleteness subtype probably actually characterizes a little bit more in terms of some of these subcortical areas, but also anterior cingulate, as well as supplementary motor area and pre-supplementary motor area. So there's kind of lots going on. There may be some differentiation based on some of these newer subtypes that we're thinking of, but we still have a long way to go in terms of characterizing them. So I'm going to talk a little bit about deep brain stimulation. We could do a whole hour talk just on each of these. So I'm going to go through some of these and kind of just at least give an overview of what's happened in OCD and kind of thoughts about even referrals for some of these procedures and who may be appropriate, and kind of the steps that we take before we end up doing these surgeries or these other techniques. So a lot of you have probably heard of DBS. DBS is commonly used in movement disorders and has been used in OCD for about the past 20 years. But still, DBS for patients with OCD remains rare. So for example, at our site, for surgeries overall, we might operate on 2 to 4 patients a year. And we're one of the biggest sites in the United States, if not the world. Here's just a quick overview of the timeline of DBS. So dating back to 1947, there were stereotactic frames made, including the Lexell frame. There were some early DBS interventions, even back to 1948. Moving forward into the 70s, there was some treatment of pain used by different types of DBS. In the 1980s, there were the first fully internalized DBS systems available. And then Benavides in 1987 reported some successful treatment of tremor with DBS, which ushered in this kind of more modern era. 1999, they moved to this dual channel, what we call IPG, which allowed 2 electrodes to be powered by 1 battery. So essentially, there is a battery typically placed in the chest wall. That battery connects via wires to the brain. And in OCD and other disorders, essentially small, thin wires are inserted into the brain that have contacts on them that are used to stimulate those areas that we talked about a minute ago in OCD. So when you move to this next one in 2002, there was this quadrupolar electrode commercially available. So you can see there's different contacts on that electrode, and we can stimulate each of those contacts in different ways. In 2009, rechargeable DBS batteries became available, which was actually really exciting because before that, our patients would have to actually get their DBS batteries replaced every 1 to 2 years. So they would get it implanted, they have to go through another surgery a year or 2 later. And that surgery can cost $20,000 to $30,000. It's again, another surgery where they're just replacing the battery. They don't have to go into the brain, but it's still quite burdensome. So the advent of rechargeable batteries was very exciting because essentially they could charge the battery kind of like you do with your cell phone by putting something over the chest. They recharge it. It would last for about 1 to 2 days, and then they can charge it again. In 2013, there's a closed loop responsive DBS system introduced. And then, as we move forward down the line, there's some DBS systems with wireless recording capability. So we're kind of moving down the line in terms of technology. I'll talk about adaptive DBS in a second. So in terms of DBS for OCD, you can see here on this side, on the left-hand side here, there's an implanted electrode, and you can see these kind of wider areas that actually are that represent the contacts. And then what this is actually blown up here, and you can see these darker areas, and this is inserted into the anterior limb of the internal capsule, or the ventral capsule, ventral striatum, in between the caudate and putamen. And each of these darker areas is a contact that can be stimulated in different ways. And so I'll move forward a little bit here. The most common targets for OCD are the anterior limb of the internal capsule, or the ALIC, the VCVS, or the ventral capsule, ventral striatum. And you see these are very close to each other. These are almost on top of each other here. And then also the nucleus accumbens, which is also, again, kind of very close to that, kind of just below the VCVS target. And these were developed to hit that aberrant neurocircuitry in OCD. So looking back, we saw, okay, well, there was some, there's clearly abnormal circuitry here based on animal models, way back even 50, 70 years ago. This led to lesion procedures, which I'll talk about in a minute, and then ultimately led to DBS and ultimately this type of targeting. And so really all of these things were empirically developed. They weren't based on MRI scans. They were developed over time based on change in behavior. And that's still actually how we're kind of looking at things now. We're starting to do more and more about neuroimaging and modeling, but really we're looking at kind of response rates. So with DBS for OCD, we typically see some clinical improvement by about 3 months, but response tends to improve with time. The average response rates when you look at reviews and look at across DBS studies for OCD is about 60%. So that means about 60% of patients get significantly better. And how that's characterized is a greater than 35% improvement in OCD symptoms. And so for a patient with OCD, that's actually very clinically meaningful. So you can go from the extreme to severe range of OCD symptoms to kind of a typical OCD patient. So someone who might have still obsessions and compulsions, but they're not necessarily interfering with their functioning as much as they were before. And so you can see, and these are patients who have tried everything else. So as I mentioned, these patients are extremely severe. Some of them, again, are still working, but a lot of them are housebound, but their functioning is extremely impacted by this disease. And so they have gone through all different types of treatments before they end up getting to surgery. So most sites, including ours, they've gone through at least 20 sessions of exposure and response prevention. And so that is done with an experienced behavior therapist. So we spend a lot of time reviewing these cases. We get records. Patients are coming from across the United States, if not across the world. And we go through all of their records. We get referrals from their psychiatrists. We get statements about the patient's experience with OCD throughout their lifetime. We talk to their behavior therapists that they've worked with before to ensure that they've actually engaged in true exposure and response prevention therapy. We talk to their psychiatrists to ensure that they have had certain trials of medications, including serotonin reuptake inhibitors, benzodiazepines, clomipramine. So we kind of go through and make sure that they've had all of these different types of medications for adequate amounts of times at adequate dosages. Because many patients with OCD actually don't get recognized, number one, and even if they do get recognized, they don't necessarily get adequate treatment. So they may not be with a psychiatrist or a therapist who actually knows how to treat the disorder very well. So we want to make sure they're actually getting the adequate treatment first before they would ever be a surgery candidate. In terms of other targets, so the STN, subthalamic nucleus DBS, our responder rates rating from 40 to 75%. But there's not as much literature on that as compared to some of the targets noted above. And the ITP, or inferior thalamic peduncle, has some mixed results in OCD. So the most common ones now that are used clinically are the ALIC and the VCVS and the nucleus accumbens. But again, these are all targets, even though they're differentiated in the literature with different terminology, they're actually very close to each other and hitting kind of these white matter pathways that connect these deep subcortical areas to the frontal systems of the brain. As I mentioned earlier, now we have something called adaptive neuromodulation. So the way DBS started was initially those contacts are used to stimulate different areas of the brain and change that neurocircuitry of the brain. But now we also have the ability to get information or gather information from those contacts as well. So the ultimate goal of adaptive neuromodulation is, so right now the way DBS works, you have electrodes implanted. You spend quite a bit of time going into typically a psychiatrist's office. So for movement disorders, it's usually a neurologist. For OCD or depression, it's usually a psychiatrist. You spend a lot of time, and the psychiatrist works with the patient with OCD to determine the best parameters for their DBS settings. And so that can take weeks and weeks at a time. And so essentially what they're looking for in the office is often a mood change. So it can be hard to elicit OCD symptoms in the office, but we can get kind of improvement in mood, or you feeling better, and then they go home and we kind of see how we monitor their OCD symptoms. They go back, we adjust it depending on side effects and depending on clinical effects. And so it's a very time-consuming process. And day to day, there may be changes in how their OCD symptoms manifest or how their mood manifests. And so it would be fantastic if there was a way to kind of modulate the system in the moment, right? So the goal of adaptive DBS is to actually understand what's happening in the brain. So understand the biomarkers of the brain, take information from those biomarkers and adjust the DBS system in response to that. So for example, I have contamination fears, and here I am, my OCD has been triggered by this, and my DBS system responds to that in an appropriate way. And so the tricky thing is that we still are working on some of these biomarkers. So we have some studies now where we're doing symptom provocation at Butler, trying to get a sense of biomarkers on using EEG signals. And then taking those biomarkers in a bigger group of patients with OCD who may not have DBS implanted, and then using that information to adjust the DBS in an appropriate way. So I'm going to talk a little bit now about lesion and ablative surgeries for OCD. So as with DBS, the lesion and ablative surgeries are also designed to hit some of this aberrant neurocircuitry. So DBS stimulates that circuitry and changes how the connectivity works. These ablative surgeries actually cause a lesion within that circuitry that we think is hyperconnected in terms of those subcortical to cortical regions that I talked about. So essentially by kind of ablating or cutting that circuitry, we're disrupting that aberrant neurocircuitry to improve symptoms. So obviously, I'm sure that most of you have heard of this long-standing history of lesions in general for psychiatric disease. So going back, 70 years, we have Walter Freeman, who actually went around the country performing lobotomies, so transorbital lobotomies. And backing up, these were used for psychiatric disorders for many years because we didn't have medications that worked. Luckily, over time, there were medications that come out, so the use of these lobotomies decreased over time. And in the late 1970s, there was actually a commission formed by neuropsychologists. There were two groups led by neuropsychologists who actually were commissioned to determine whether lesions were helpful in psychiatric disease. And they ultimately determined that there were a large number of patients that were actually had improvement in symptoms after these, even these lobotomies, but clearly there was widespread misuse of these techniques. But there were some patients that did improve, but they actually recommended that there be a registry so we could follow these patients over time. So obviously we're not doing lobotomies anymore. Our lesions have gotten much, much smaller. And we lesion a very discrete area, which I'll show you a picture of in a minute. So there are a couple techniques that use, or modern techniques in terms of methods of ablation. So traditionally, lesions were made using radio frequency. So essentially this made a lesion using heat through an intracranial placed electrode coupled to a radio frequency generator. So essentially an electrode would be put into the brain, directed to the target where it needed to go. The base of the electrode would be heated up, and that would cause a lesion, and then the electrode would be removed, and that would leave a permanent lesion in the brain. And so those lesions have been done for about 40 or 50 years, I believe. And so Mass General Hospital still uses this RF technique to make cingulotomy lesions. There's also a newer technique called laser interstitial thermal therapy, where we also similarly insert laser fibers actually to the target, and where this is actually the technique we use at Brown now. And MR guidance and MR thermography allow precise real-time monitoring of the procedure. So essentially we insert laser fibers in the OR. The patients are then moved to an MRI scanner. The lesions are actually made in the MRI scanner. We take an MRI scan every 6 seconds, and we're able to see the lesion being formed using MR thermography. So we can see how big the anticipated lesion will be, and then how big the lesion is after we actually lesion it. And we adjust the lesion size related to what we're able to see on the MRI. Another technique that's been used in a fairly widespread manner, is still used today, is stereotactic radiosurgery, or for example, gamma knife or cyber knife, which delivers a large single dose of radiation to a target while sparing surrounding tissue. So here, this is an Electa machine, which is one of the widest uses of gamma, one of the manufacturers of gamma knife. And so essentially, it looks kind of like an MRI scanner. A patient will go in, and there's a bunch of little holes called collimators. And through each of those collimators, there's a gamma ray that goes through. And where that gamma ray, so each of those gamma rays alone doesn't cause any damage. Where those gamma rays intersect, it can actually cause a lesion in the brain. We used the gamma knife for many years. So we started using the gamma knife in 1993. And I believe we did our last surgery in 2012 or 2013. It worked very, very well for many patients. I'll talk about in a minute. But we did have some side effects, which led to moving on to another technique, which I'll circle back to in a minute. Another method of ablation is MR-guided focused ultrasound. This is a newer technique where they use high-intensity focused ultrasound beams, which are targeted to a region using a hemispheric phased array of transducers that is fixed to the skull. So it's actually using an ultrasound technique to create a lesion in the brain. So I talked about methods, right? So there's multiple different methods, and then there's also different targets, right? So I mentioned cingulotomy. So cingulotomy has been done for many years. Mass General Hospital, I believe, is the only place in the US that still carries out cingulotomies on a consistent basis for OCD. And so these here, the second panel down where we see these 3 lesions in the anterior cingulate, that is right after the procedure. And then you can see the ultimate lesion to the right of that. There's capsulotomy, which is what we actually do here at Brown, and many other sites do, including Baylor, University of Chicago. And that is where we create a lesion in the anterior limb of the internal capsule, which you'll remember I talked about with DBS as well. So the target is very similar. So again, hitting that same circuitry. The DBS target is actually a little bit closer to the anterior commissure. I don't have a great picture here, but if you can imagine, we have the anterior commissure here. The DBS target is very close to that anterior commissure point. And then if you move anterior to that in the brain, we actually have the lesion region. And the reason for that is because what happens is at the anterior commissure, these fiber pathways are really tightly pushed together. and then they spread out as they kind of progress to the frontal lobes. And they also turn and hit kind of ventral prefrontal cortex. And so with DBS, we can hit that tighter circuitry because we can turn off DBS. We can turn it on and off. We can adjust the parameters. We don't want a lesion there because we actually are more likely to get more significant side effects if we're lesioning there because the fiber pathways are so close together. So we actually lesion a little bit further out where those fiber pathways are a little bit spread out. But again, those pathways are generally consistent. It's just kind of different points in the pathways that then connect to different areas of the prefrontal cortex. There's two other techniques that are not quite used as often and have never been used as often as capsulotomy and cingulotomy, but one is subcaudate tractotomy, which is right down here, and then limbic glucotomy, which is actually a combination of subcaudate tractotomy and cingulotomy. Mass General has done limbic glucotomies primarily both in OCD and depression. If a patient, for example, gets a cingulotomy, they don't have any effect, they'll add on a subcaudate tractotomy later to see if they can get an improvement in symptoms. Or at times they have done a limbic glucotomy all at once, so lesions 2 different areas of the brain, especially in cases of aggressive patients. So not necessarily patients with OCD, but patients with significant aggression. But they've only done a handful of cases like that, from my knowledge. So again, this goes into some of the circuitry here that I was just talking about. So thermocapsulotomy, being essentially using that thermal probe and causing a lesion. Gamma ventral capsulotomy, which uses that gamma knife that I talked about, where all those rays are put in and then we lesion at that targeted area. And then VCVS deep brain stimulation. So you can see here on this axial slice, so as we get closer to the anterior commissure, we have the target for VCVS DBS. And then as you move forward, we have the target for gamma knife and then the thermocapsulotomy lesions that can overlap with the gamma knife lesion, but we're typically a little bit more anterior. But you can see they're all kind of coursing along these same white matter pathways. So it's not necessarily that we're destroying one area of the brain, but really we're looking at changing these different pathways that are connecting these different areas. So as I noted, we've used gamma knife for many years. We started using it in 1993. So the chair of our department, Steve Rasmussen, began using gamma knife for OCD in 1993. And we typically, and based on 40 patients that were treated with this, what we call double shot procedure, which you can see a picture of here, where we did 2 lesions along the length, if you're looking in the coronal plane of the internal capsule. We had 69% full responders. So again, those who had greater than a 35% reduction in Y-box score, and 23% partial responders at 2 years after surgery. So again, that's a pretty good outcome considering that these patients didn't respond to anything else, and that this was actually able to be quite successful in terms of reducing their symptoms. We did have minimal side effects. So I'm actually finally working on finishing up the initial neuropsych paper on this. This paper was published in 2018. But fortunately, we don't have any negative cognitive side effects. So we actually have improvements in confrontation naming on the Boston naming test, which may be a practice effect. We also have improvements in full-scale IQ and performance IQ, which I suspect is a function of processing speed, not necessarily IQ changes. And we also have improvements in the Wisconsin card sort, which also may be a practice effect, but certainly no declines over time, both on a group basis or when we're looking at individual scores in terms of pre-post neuropsych testing, both about a year after surgery as well as down the line. So we continue following these patients. I've done neuropsych testing on patients who are 20 years post-surgery at this point. And we typically see good outcomes over time with regard to safety in most of the participants. Now I say most because we did have a couple patients who did have cysts in the brain. So we have 3 patients who developed cysts as a result of the radiation dosage that they received. And so 2 of them didn't have any side effects. We just happened to catch it on follow-up MRI scans. One patient did have some visual changes and had to get a neurosurgical excision of the cyst, and had some complications after that. And so because of those side effects, we actually paused doing the gamma knife for a bit of time to try to figure out what was going on. And we realized it was actually having to do with the overlap in radiation in a certain area of the brain due to a change in the gamma knife model, which is a long story that I'm happy to talk about, but don't have a ton of time to go into right now. And ultimately, like I said, we paused doing the Gamma knife, and then we ended up switching over to this LIT procedure, this laser interstitial thermal therapy. And we did our first patient with LIT in December 2016. Now with Gamma knife, what we noticed was that we can target this area of the brain, this anterior limb of the internal capsule. But the tricky thing is that everyone's brain responds differently to radiation. So some patients wouldn't develop any lesion. Some patients would have much larger lesions. It was really unpredictable in terms of size. And we had to wait 6 to 12 months to see the lesion because it takes some time for the lesion to develop, because essentially it's causing radiation necrosis and changing the cells in the brain. And so it takes a while for those lesions to develop. So most of the lesions didn't look nearly as perfect as these here in this picture. So again, we paused because of some of these side effects. We switched to LIT, which I mentioned earlier. And the benefit of LIT is, again, we are able to do MRI scans every 6 seconds. We can see where the target is. We can see the lesion. So we can really get a better judge of how much we're lesioning and have a lot more control over that. So the downside to LIT is that it is more invasive. We do have to put a burr hole in the brain and put leads into the brain that are removed later, versus the Gamma knife is completely non-invasive. So this is LIT for OCD, like I just mentioned. So patients, again, are in the OR, and then they go into an MRI machine, and we have this software where we can see the lesion being formed, which is an example here from one of our patients. So you can see this thermography that shows about the size of what the size of the lesion will be. And we're able to do that while we're doing the lesion procedure. And then afterward, we're able to go back in and just double check if the lesion is at the size that we wanted. And so I published a paper on this last year with our first cohort of patients, and we had 7 out of 9 responders. So I think that's probably a little bit high given the small sample. I anticipate we'll probably be around 60-65% response rate once our sample gets a little bit bigger. So the response we consider pretty similar to Gamma knife, which is what we'd expect, because essentially we're lesioning the same area of the brain, just with a different technique. And you can notice that earlier I said DBS has about a 60% response rate too. And so DBS and lesions are pretty consistent in terms of response rate. So I've been referencing along the lines who qualifies for DBS or ablation for OCD and how few patients we actually ultimately see. And so one of our prior postdocs, who's now a faculty member, Sarah Garnot, did a study where she looked at, this is a study, it's the blocks study that looks at patients with OCD and just follows them over time. So these are non-surgical patients, or patients who are coming for treatment. And we started with 325 patients. And then essentially we said, okay, well, what happens if we apply surgical criteria to this cohort of patients? So we said, okay, if they have a Y box greater than 28, because that's typically what we require for surgery. So this is in the severe to extreme range of OCD symptoms. So if you apply that criteria, we cut it down to 63 patients. Those who have had at least 3 SRI trials, we go down to 32 patients. We require that patients who are undergoing surgery have tried clomipramine, because it can work well in treatment-resistant OCD. If we apply that criteria, it goes down to 20 patients. And we say, okay, have they had at least 20 ERP sessions? We go down to 6 patients. So you can see this number is dwindling down. And then if we apply our other entry criteria, including, lasting at least 5 years, we look at their functioning, only 2 patients out of 325 patients would actually have been eligible for surgery, or less than 1%. Now, when to refer? So while most of our referrals actually come from either psychiatrists, a lot of them come from the patients themselves. So we get many patients or family members who email me, call me, and they say, hey, we don't know what to do. My family member, myself, I'm really significantly impacted by OCD, and I saw your information on the internet, or I heard a news story about you, and so I'm seeking help. But it is, I think, important for us as neuropsychologists to know, both for these type of procedures as well as the non-invasive procedures, when might it be important to talk about this with a treatment provider if you happen to see a patient with severe illness. So symptoms are not well controlled. Symptoms are significantly reducing the patient's quality of life. And also with, like I said, in OCD, they've tried everything else. So they've tried lots of ERP, they've tried all of these SRIs, they've tried antipsychotics or neuroleptics, clonazepam, clomipramine. A lot of our patients now have done residential treatment programs. They've also done, many of them have now tried ketamine or TMS. So many of them have had all of these other different types of treatments before they get to us. And we do want them to have tried those things because we don't want to just jump into brain surgery. One thing to note when we talk about DBS versus lesions, so patients often come and they say, should I get DBS? Should I get a lesion? I mentioned that there's not many sites in the world, and including the US, that do these procedures. So this is an example of OCD, DBS, and lesion surgery sites in North America. So you can see the purple ones are those who do DBS and lesions, and the red ones are those who do DBS alone. You can see we have a cluster in the Northeast, which is great, but there's big chunks of the US where really there is no option for this. There's a very few number of centers and few expert sites for DBS adjustments. And like I mentioned, for DBS, the initial optimization can be time consuming and long-term care is essential. So I mentioned we follow our patients indefinitely if they let us. So we're always here for them, even 20, ultimately at some point 30 years later. We get calls from other patients across the United States who have had DBS, because a surgeon could technically do DBS or a lesion without necessarily having a team behind them. We get calls and the patient says, I received DBS from a surgeon. I don't have anyone to do the follow-up or do any of the optimization. What do I do? And that's a really tricky situation. We help them as much as we can, but if someone is in, Colorado or Utah and, we're in Rhode Island, it's really hard to do this from a remote distance. So we'll talk about this a little bit more. So one reason to choose lesions versus DBS, for example, are adherence concerns. So if there are indications that a patient's not adherent to medication or other types of treatment, they might be non-adherent to a device. Some OCD patients may have difficulties with decision-making or have just right symptoms that will lead to requests for continued adjustment for parameters. So for example, we had a patient who we just did a lesion on because otherwise he would continually probably come into this office, the doctor's office saying, I want you to try this. I want you to try this. This doesn't feel right. I want you to do this. And continual adjustments where you can't do that with a lesion. Also medical concerns. So patients with comorbid eating disorders that may impact placement of battery due to low fat or muscle content. Comorbid skin picking may lead to infection in a burr hole. So if you thinking of an open procedure, we want to be careful if someone has a lot of skin picking, which is often comorbid with OCD. Also convenience. So DBS needs to be charged every day to every few days. So it is adjustable, but again, there's a lot of upkeep. The DBS batteries will eventually die, requiring additional surgeries. So although we have rechargeable batteries now, which are fantastic, ultimately those batteries will die. We estimate probably in 10 to 15 years, but our mean age of our patients is 34. So if you think of someone in their 20s or 30s, they will likely still need several surgeries throughout their lifetime. Because DBS, we can't take it off at some point. If it's working, it's working. If it's off, it's not working anymore. And so typically we anticipate that it would be on for the rest of their lives. Also constantly being aware of a device inside your body. So like if you're going and getting an MRI scan or traveling and having to think about having something there. Lesions are typically completed in one visit with no need for continued adjustments, but they're also not reversible. So once it's in there, it's done. DBS you can remove and may have a little bit of a change in your brain, but not necessarily to the extent of a lesion. Symptoms will return almost immediately when DBS is turned off, the battery is not charged, or the battery dies. But on the other hand, the parameter settings are adjustable, unlike lesions. One thing to keep in mind is the cost and the burden. So these surgeries are incredibly expensive, so ranging depending on the hospital, depending on the method, from $10,000 to $120,000. So DBS is likely more expensive than, for example, a lesion procedure like LIT. DBS and LIT, the initial cost is probably very similar, but the long-term cost may be more expensive for DBS. DBS is likely more expensive than a heat lesion or a gamma knife lesion. Insurance may also not cover surgery, particularly in DBS. So this is a recent article that we published, a group of experts talking about restriction of access to DBS. So failure to apply the Federal Parity Act, because DBS is usually covered for movement disorders, but a large percentage of the time is not covered in OCD, which is, a lack of mental health parity. And so it's been a huge issue. For some reason, a lot of our lesion procedures are covered, but DBS hasn't been consistently covered. DBS is often more expensive for long-term care. So you need more frequent psychiatrist visits. You need to be close to someone who knows what they're doing. You also need additional surgeries in the future, like I said, once the battery dies. And these may not be covered by insurance, even if the initial surgery was. So for example, if we get a patient who happens to have Medicare coverage, which has happened before for DBS, because they're on disability, DBS works, they come off disability, which is fantastic, right? They're able to go back to work. They don't have Medicare anymore. Their new insurance company says, hey, well, you had this covered under this prior insurer. This is a previously covered surgery. We're not going to cover the battery replacement. And the battery replacement in and of itself can be $20,000. Interestingly, in terms of clinician perspective, so we have this long-standing concern about using lesions in general in psychiatric illness due to some of the concerns I talked about earlier. And so DBS is typically perceived as actually safer and more effective than lesion surgeries. So this is actually a study that we've been working on where, there's a lot of information here, but essentially it basically says that clinicians essentially are saying that neurocircuitry-based procedures in terms of DBS, which is this green versus the teal lesions, are actually both more effective, which is on this side, and see on the left side, and safer on the right side. So you can see more people say that DBS, they say they strongly agree that they're more effective as compared to lesions, and same thing for safety. But in reality, the safety and the effectiveness of both of them are actually pretty comparable. All right, so I just ran through our invasive treatments. I'm just checking the time here because we don't have a ton of time left. So I'm going to talk a little bit about some of our non-invasive treatments. And so why would we do non-invasive stimulation for OCD? So I talked about these invasive treatments, how well they can work for patients who have really failed at so many other things. Why, right? So a vastly larger pool of patients might be candidates. So I mentioned earlier, maybe we get 1% of patients who might be eligible, of patients who have OCD for surgery, right? We can potentially hit a larger number of patients who may not be quite as severe or in the extreme range of OCD. Also, the cost and logistics of care are relatively favorable. So these non-invasive stimulation techniques are typically much less expensive than the other techniques. So why not, right? So DBS and lesions, once someone has a clinical effect, those clinical effects seem permanent. They rarely, although there's still may be some persistent OCD symptoms, it's not like we're curing the disorder, and there still may be waxing and waning over time. Typically, if there are improvements, those improvements are long lasting. With non-invasive stimulation, it can be challenging to get lasting effects. So we might see an effect in the moment, but it's hard to know how long that effect's going to last. We still don't have a ton of information about that. And, it certainly is not a permanent change if we're doing kind of a course of TMS or TDCS or something like that. In TDCS, I'm going to talk about each of these individually. So we have acute effects being relatively local for TMS, or broader for TDCS. Oops. So what is TMS? So TMS is a non-invasive procedure, and a lot of you have probably heard of this before, that uses magnetic fields to stimulate nerve cells in the brain. The frequency of the pulse delivery also influences whether brain activity is increased or decreased by a session of repetitive TMS or RTMS. So 1 Hertz is typically, which is low frequency, is typically classified as inhibitory TMS. 10 Hertz, which is high frequency, is typically classified as excitatory. Again, I'm kind of going through this as a quick overview. We could easily have an hour talk just about TMS. And experiments on the human motor cortex have been done in theta burst stimulation, which is a different type of TMS that can actually be done in shorter amounts of time, have shown that I-TBS has facilitatory effects, and C-TBS so I being intermittent TBS, and C being continuous TBS, so continuous TBS having inhibitory effects. So a quick timeline of TMS therapy. So this goes all the way back to 1790s, where we discovered that nerves carry electrical energy, moving up to the first TMS device in 1985, going through release of TMS safety guidelines in 87, some safety studies in the 1990s, the FDA approving TMS in general in 2008 for depression, and then US health insurance companies beginning to cover TMS for depression in 2013. So TMS now is commonly used as a treatment for depression, and insurance companies often cover it, and it typically works pretty well. Now for OCD, it's a little bit of a kind of a newer time period. So the first study, I believe, for OCD was done in around 1998. And then there wasn't a ton of research in TMS for OCD for many years, but now it's kind of been a resurgence over the past few years. And in 2018, there was the first FDA clearance for OCD with a BrainsWay device, which targeted pre-supplementary motor area for OCD, which, as you remember, so we talked about the invasive procedures targeting those subcortical areas. TMS is targeting those cortical areas now. And then 2022, so this year, Neuronetics was also FDA cleared for OCD treatment. So early studies targeted DLPFC in depression with varying effect, as in depression with varying effects for OCD. So they said, well, DLPFC, dorsolateral prefrontal cortex, worked in depression. Let's see if it works in OCD. Not so fantastic. It doesn't work great in OCD. Occasionally you get effects depending on the study you're reading. So they started examining some other targets based on the neurocircuitry implicated in OCD and related disorders, including tics. Early research showed decline in OCD symptomatology with supplementary motor area stimulation. And then in addition to SMA, researchers have examined other targets like orbitofrontal cortex. There's only a few studies there, but it might be a promising area. And like I mentioned, TMS to the pre-supplementary motor area was FDA approved for OCD in 2018. So here is me being stimulated for one of our studies. So where we were actually targeting pre-SMA, so you see this big coil here, which is the big TMS device. And there are different types of devices. Some of them look more like helmets. This is a MagStim coil that we were using for a research study. So this is not one that is FDA cleared, but we were targeting the same area of the brain that is used in the approved technique. The approved technique, it's designed actually to do kind of a provocation during the stimulation. And then there's also transcranial direct current stimulation, which is another type of non-invasive technique. And so here's one of my lovely prior research assistants. So this is a study that we did looking at transcranial direct current stimulation. And we had one of the electrodes, so the cathode centered on the top of the head, and then the anode on the right cheek. So this was again hitting pre-SMA or SMA, and we were trying to get improvements in OCD symptoms. So we were using this facial slimming mask, which is what is on her face, to hold on those electrodes. So TDCS, is a non-invasive, again, painless brain stimulation treatment that uses direct electrical currents to stimulate specific areas of the brain. So we have a low intensity current that's passed through those two electrodes placed over the head, which modulates neuronal activity. So anodal stimulation is typically considered excitatory, cathodal inhibitory. And so TMS actually forces an action potential to occur. Okay. TDCS actually makes it more likely or less likely that an action potential will occur. So they're slightly different in terms of the magnitude of effect. Both of them, both TMS and TDCS, have relatively few side effects. The most common side effect of TDCS is a slight itching or tingling on the scalp. We also have now something called HD TDCS or high def TDCS, which looks more like an EEG cap. We're using this for a study now where it's theoretically a little bit more targeted in terms of brain region. So here's just some initial findings, for example, from one of our study that's showing changes in functional connectivity related to, so left IFG and thalamic connectivity is related to change in Y-box score in this study that we did looking at pre-SMA transcranial direct current stimulation for OCD. Now, TDCS is not approved for OCD treatment. There are some places you can go where you can get TDCS treatments for OCD, but you're paying out of pocket. It's not an FDA approved treatment. This is really more in the research stages as compared to TMS. So it's just a quick slide here that I'm not going to go too much into, but next steps, we're thinking a lot of you have probably heard about NIH's research domain criteria, which is essentially looking not just at disorders per se of how we kind of group people in terms of putting people in boxes, but really looking at a cognitive construct or a different type of construct and changing that. So for example, I've been working a lot on response inhibition and inhibitory control and figuring out, can we change someone's inhibitory control by using stimulation, brain stimulation? And that could be potentially applicable to lots of different disorders. So it could be applicable to OCD, because if we can improve inhibitory control, someone might be able to resist the compulsions a little bit more, which may allow them to have a better outcome in exposure and response prevention therapy, for example. Could also be important in something like substance abuse, where if we improve inhibitory control, we can make people less likely to engage in using substances. So we can talk about these constructs as being really applicable across multiple disorders. And that really, when we're doing brain stimulation, it's not necessarily that we're saying, oh, well, we're changing just OCD symptoms and that's it, or we're just changing mood symptoms. Really, we're changing, as neuropsychologists, we know that different area of the brain may impact different types of cognitive or affective functioning that may impact across a lot of different disorders. This is just what I was talking about here in terms of inhibitory control. And then I'll just mention briefly low intensity focused ultrasound, which is, so we can kind of go from TMS, which is pretty well established at this point, a little less well established for OCD than depression, and kind of becoming more established for other disorders. TDCS, which is really still in the research stages, but has some evidence showing that it might do something. And then we move into low intensity focused ultrasound, which is still in really early stages in terms of how well it works and to some extent safety. So TMS and TDCS are broad, typically not very specific anatomically. They also can't target deep subcortical structures. As I was talking about earlier, some of these invasive techniques that hit these deep subcortical structures, at least in OCD, work really well. But with TMS and TDCS, we're only limited really to cortical regions that may have some connectivity with those subcortical areas, but we're really not hitting those subcortical areas directly. So there is this newer possibility of LIFU, or low intensity focused ultrasound, which overlaps with this high intensity focused ultrasound, or HIFU, that I mentioned earlier, but a lower intensity, obviously. And this may modulate neuronal excitability. And recent observations have shown that it can activate voltage-gated sodium and calcium channels, eliciting action potentials and synaptic transmission. But ultimately, it's again using ultrasound waves to modulate brain activity, but in a temporary way. So we're not causing a lesion like with high-intensity focused ultrasound, but could potentially change things in a shorter-term or temporary way, but that may over time cause longer-term changes. But again, this is really early in research stages. All right, so our takeaway, we have some strong neurocircuitry-based therapies, though many are invasive and only appropriate for the very severe. We're developing more novel techniques that might be used for more patients. And ultimately, as much as I, really think that these invasive procedures can work really well in a subset of patients, it would be fantastic if we had other techniques that we didn't have to go in and lesion or put devices in the brain, and we could use something else. And we're moving now away from diagnoses to really targeting different kind of cognitive and affective constructs. All right. So any questions?
Yes, thank you so much for this talk, Dr. McLaughlin. I feel like it's a really interesting topic, and as somebody like myself right now who's doing some work with DBS candidates for movement disorders, it's great to hear about both sort of these more intensive and non-invasive interventions for OCD. We have one question from the audience. If anyone else has any questions, feel free to put in the chat now. We have about 5 minutes. But one question I have for you, just through your role with the Brown Consortium and the training program and the various trainees you work with there, what sort of advice would you give to a trainee who might be interested in sort of having a role like you do now, where you're involved in sort of evaluating candidates for these types of interventions and the changes that have occurred after the interventions? What sort of advice would you give to them, or what sort of steps do you think would be beneficial?
Yeah, so I think that, certainly if possible, finding a training program that offers that. I think it's tricky because, like I said, there's very few places, at least for psychiatric disorders, that offer this kind of training. And how I never necessarily anticipated running a psychiatric neurosurgery program, especially as a neuropsychologist. Most of them are run by MDs, and it took a bit of time to actually kind of get to that point where they actually kind of trusted me, I think, a little bit in terms of running the program. But realized we have really good neuroanatomy training and know a lot about the brain, and so that it works well in this kind of situation. But I kind of happened into it over time by starting to work on some research studies related to DBS and running the neuropsychology side of things for a multi-center DBS study. And that transitioned over to taking over more of a role in these lesion procedures. But I think finding a place where, if there's something you enjoy doing, finding a place where there are opportunities to be able to participate in these things. And at least while the invasive piece, is not offered at very many places. There now TMS is really becoming much more widely used, and I think there's many more opportunities for training opportunities there at different sites. And really, I think having the value of what we do as neuropsychologists and being able to bring that to the table, both in terms of looking at changes, but also helping with targeting and changing targeting over time and figuring out kind of where the best places are to go in terms of, adjusting the stimulation sites, for example.
Great, thank you so much. I guess while we're on that topic, before I ask the other question that came in, we got one other question, just kind of generally, if there's any good references or additional readings you might recommend for somebody starting out in the field who's interested in sort of OCD and these sort of interventions.
Yeah, there are. It would be hard to just kind of rattle them off right
Sure.
now. I don't have, so my email, I'm happy to give out my email. My email is Nicole_McLaughlin@brown.edu. So that's pretty easy. You have my name, I think, on the website. So you just my name, first name _ last name @brown.edu. If anyone wants to email me, I'm happy to answer questions over email. I'm happy to provide more information about reading materials, because there's certainly a lot of review articles and chapters and things like that. And
Yeah, that's all.
I could have talked an hour on one of these things alone. So I kind of over so much of this today. Yeah,
I feel like the overview is really, I think, a nice place, especially since the field has a long history and is moving in a couple interesting directions. I guess the last question, maybe just for the sake of time, we had a question, essentially, you talked a lot about the effectiveness of these therapies in terms of like changes in the Y-box score, for example. Are there any studies about patient satisfaction and sort of what are differences between sort of, I guess more broadly, not the Y-box score, but their sort of personal feelings toward these surgeries and interventions?
Fantastic question. And the answer is there's not that many, sadly enough. However, I actually had a student, a Brown undergrad, who came to me now probably 7 years ago, 7 years ago, and started working with me. And he stayed on at Brown as a medical student, Adriel Barrios Anderson, and he actually did a qualitative study looking at patients' lived experience after surgery for OCD. And so that was a good way to kind of have a good understanding of not just these kind of quantitative outcomes, which are important, right? OCD score, we talk a lot about OCD score, and it is important. Although even with quantitative outcomes, we think that the functioning is actually more important. And we do have ways of measuring that. Again, maybe not the most fantastic ways. I think we have to improve that, but also getting some of the qualitative information from patients is really helpful. So understanding both, how we are doing in terms of the lead up to the surgery, right? It takes a long time to get to the surgery point. How are we doing in terms of helping patients to that? What is it like going through the surgical process? What is it like after the surgical process, from really that lived experience? So we do have a published article on that, but I think there's still a lot more work to be done.
Awesome. Well, thank you so much, Dr. McLaughlin, for joining us today and for this excellent talk. It certainly is a very unique talk, I think, that you've given us, and just your research in general. The work you do is great. So I'm pleased, I'm looking forward to continuing to follow your research in the future in this area. And thank you for being a part of our resources today for these, for the people who watch the Neuropsych Didactic series. Really quickly, I'm just going to share my screen here. So next week, we are not having a talk if you're one of the people who are regularly coming live because of, so I have the wrong slide open. Next week, we are not having a talk basically because of the Thanksgiving holiday in the United States. But the following Monday, November 28th, we're going to have Dr. Maria Diaz-Santos from UCLA joining us to talk about community neuropsychology and decolonizing research in neuropsych. So thanks again, Dr. McLaughlin, for joining us today. And I hope everybody has a good rest of your day. Bye, everyone. All right.